Okay, folks, now let's please. The last chapter, chapter 25. It says the disorders of the bladder, urinary bladder, and lower urinary tract. Lower urinary tract, I mean, we're talking about the urethra. Bladder and the urethra. Structure of the bladder, we have parts we call fundus of the bladder, or fundus, which is the body, and the neck, which is posterior urethra. The bladder muscles is detrusor muscles, and so it says urine passes from the kidney to the bladder through the ureter. Kidney and ureter both are retroperitoneal structure. Kidney and urinary bladder, they are both retroperitoneal structure. That means what? Retroperitoneal means kidney and ureter are retroperitoneal. What does it mean? What does it mean by retro? Back, behind the peritoneum. Kidney and ureter are behind the peritoneum. That means my anterior surface of the kidney and the anterior part surface of the ureter are covered by peritoneum. Posterior surface? No, because my kidney is retroperitoneal. Retroperitoneal. So the ureter, which enters the urinary bladder bilaterally at a location towards its base and close to the urethra. We do have trigone over there on the posterior surface, posterior wall of the bladder. We have trigone. These are triangular area bounded by the ureters and the urethra. On each side of the triangle, we have ureters, and the apex of the triangle, we have the commencement of the urethra. Now, the four layers of the bladder, the outermost outer serosal layer covers the upper surface, is continuous with the peritoneum. So the superior surface of my bladder is covered by peritoneum. We do have smooth muscles for the bladder wall. We call the detrusor muscles. Detrusor muscles is a network of smooth muscle fibers. Smooth muscle fiber, detrusor muscle. Now, we do have some mucosal layer, which is made up of loose connective tissue, and the innermost is mucosal. Mucosal is formed by transitional epithelium. Now, this trigone, which is triangular area, this trigone is highly sensitive. I said trigone, which is triangular shaped area on the posterior wall of the bladder, which is highly sensitive. If we put catheter, patient with head injury in ER or with any other condition, when patient need catheter, if my tip of the catheter touches the trigone, even the patient is in coma or semi-coma or conscious, patient becomes restless. Rest because the trigone is highly sensitive, and if the tip of the catheter touches my trigone of the urinary bladder, that gives me indication, a sign that something is wrong with that catheter. I need to pull a little bit, an inch or inch and a half, full or half inch, pull the catheter a little bit out, patient will become calm. Because my tip of the catheter was touching the catheter or trigone, patient is restless. So it's so important. I had to know why the patient is restless. Patient was not doing, before the catheter, patient was not doing anything wrong. Patient was not restless. As soon as I put the catheter, something went wrong during catheterization. Is it clear? That's the trigone. It's highly sensitive. Sensory receptors, the trigone are huge in number. We already mentioned about the layers. Now, this thing, PowerPoint also has a diagram in the textbook. Three main levels of neurologic control of the bladder functions. One we call the spinal cord reflex centers, which is located in the spinal cord, level from S1 to S4, and which is my parasympathetic, and thoracolumbar, which is thoracic 11, 12, and L1 and L2, which is my sympathetic. Innervation coming from my pelvic nerve, which innervates the detrusor muscles, pudendal nerve, and we do have hypogastric nerve. Look at the diagram, the textbook is pretty clear. Then we do have a micturition center, which is located in the pulse. And we do have a control from the higher center we call cortical center. Even I feel like, but I can stop because of my cortical and subcortical centers. They have a say or control. Is the following statement true or false? Micturition reflex involve both sympathetic and parasympathetic, of course, both. The reflex is both conscious and unconscious. Now, if you look at this, in the urinary bladder, we store urine, the storage and emptying of the urine. Storage function, which involves number one, involuntary, that is my autonomic nervous system, and the voluntary, which is my somatic nervous system. Autonomic nervous system, which is my sympathetic, parasympathetic, and the somatic nervous system is coming from the spinal cord. Parasympathetic, highlight and remember, parasympathetic system promotes bladder emptying. I micturate with the help of parasympathetic stimulation. Now, sympathetic, on the other hand, promotes bladder filling. Now, the striated muscles, we do have two sphincters over there, internal urethral sphincter and external urethral sphincter. External urethral sphincter, if you remember, that is 100% voluntary. Internal urethral sphincter is 100% involuntary. Now, the striated muscles in the external sphincter and the pelvic floor provide for voluntary control of urine. Sometimes this voluntary control become inadequate, become weak, and patient or person, or especially in old age and female also, they do suffer from incontinence. Incontinence, they can control. Okay, that we're going to discuss. And we do have low pressure urine storage. Autonomic drugs, they are receptors which works on receptors. The drug which depends on those receptors, nicotinic receptors and muscarinic receptors, which is meant for my autonomic nervous system. Sympathetic neurons increase bladder storage. Urine, because of the sympathetic neuron stimulation, which is my nicotinic by means of nicotinic receptors. It helps to retain urine in the bladder, increase bladder storage. Muscarinic receptors, which inhibit sympathetic neuron. So we do have nicotinic receptors and muscarinic receptor, which inhibit my sympathetic stimulation. Now we do have tests. Number one, urine test and studies, laboratory and radiographic studies, urine test, and plain X-ray. Plain X-ray we call plain X-ray of KUB. Plain X-ray of KUB region, kidney, urinary bladder. Then we do perform urodynamic studies in the form of uroflowmetry, how much urine is coming out, cystometry, see how much the bladder is holding the urine, and number 3 is the urethral pressure profile. Because when the bladder is contracting, the muscles contracting, urethral pressure has to go down so that urine can flow through the urethra. We do check sphincter electromyography and also ultrasound bladder scan. I mentioned about the ultrasound bladder scan. If person is not satisfied, if the patient or person is not satisfied with his or her urination or voiding process or maturation process, that means, and plus he or she is visiting, that means there is something wrong in the bladder wall, urinary retention, I mentioned earlier. So in order to check urinary retention, suspected urinary retention, we need to perform ultrasound bladder scan and ask the patient to urinate and check again after voiding. Increased post-voidal residual volume is the result of hematuria, is the result of detrusor muscle weakness, infection, or drug treatment. Because detrusor muscle weakness, that's causing retention. Detrusor muscle weakness result in decreased void pressure, and therefore greater volume left in the bladder. Look at this one. I mentioned urinary retention. That is urinary retention. Urinary retention. My detrusor muscles are weak. Okay, so please remember. Now, alteration in bladder function. Bladder function is altered now. Types: urinary obstruction with retention or stasis of urine. Number 2 is urinary incontinence. Please highlight both of these, or urinary obstruction with retention, urinary incontinence with involuntary loss of urine, no control. Now, causes may be structural changes in the bladder wall, structural changes of my urethra or surrounding organs, impairment of neurologic control of the bladder functions. Signs of outflow obstruction and urine retention. Bladder is distension of the bladder will take place. Hesitancy, straining when initiating urination, and small and weak stream. Frequency. But these are all important findings when the person is suffering from obstruction or urinary retention. We take history. And filling of incomplete bladder emptying. And the last one we call overflow incontinence. Overflow incontinence. Common causes for neurogenic bladder. Maybe patient had a stroke, or maybe due to advanced age. Parkinson's disease, I mentioned earlier. Spinal cord injury. Injury to the sacral cord or the spinal root. Radical pelvic surgery after surgery, or diabetic neuropathies. And the last one is multiple sclerosis. Please remember, I mentioned about the Parkinson's disease this morning. I mentioned about the multiple sclerosis, MS. The bladder become what? Bladder is getting neurogenic bladder. Now, spastic contraction, spastic bladder dysfunction, failure to store urine. Bladder is muscle becoming so much contracted, I cannot hold the urine. It's called spastic bladder dysfunction. Neurologic lesions above the level of the sacral cord of the spinal cord allows neurons in the micturition centers to function reflexly without control from the CNS. So the muscle become contracted, the detrusor muscle contracted, they are unable to relax. That was the one we just mentioned. It is spastic contract, and now we are just saying it is bladder become flaccid. Bladder now become, when the bladder become flaccid, we are going to have difficulty in urination. Bladder emptying is impaired. And because of this, it is flaccid, neurologic disorders affect the motor neurons in the sacral cord or the peripheral nerves that control my detrusor muscles, and thus bladder emptying. Because parasympathetic helps in emptying of the bladder, and the sympathetic nerves help to hold the urine in the bladder. The goal of treatment for neurogenic bladder disorders, prevent bladder over distension. That is the important. Now, also, when the bladder is getting neurogenic, the holding of urine is there, then there may be chances of UTI. So we need to be very vigilant. We don't want the patient to develop UTI because of this neurogenic bladder infection. And also, when we catheter this patient, also, we need to be, nurse need to be very careful. She or he need to watch the signs and symptoms of urinary tract infection. If the patient is having any sort of temperature or not, or patient is complaining any dysuria or not. So nurse should be very vigilant because she already introduced catheter. The catheter is the foreign body that might lead to infection. So nurse need to be very careful because she did it for good reason, and for good reason she need to be very careful. We don't want infection around the catheter. Okay, so prevent urinary tract infections, prevent potentially life-threatening renal damage, reduce the undesirable social or psychological effect of the disorder. We need to make this patient as comfortable as possible. Possible means we need to take care of this patient personal hygiene. Not only personal hygiene, also the smell. Because the patient wants to avoid the social gathering because if he or she goes in the gathering, because of the smell, the people is not going to say anything, but they will maintain distance. That's the last one what is important. Reduce the undesirable social and psychological effect of the disorders. Treatment for neurogenic bladder disorders, catheterization. Later on, bladder training, retraining. Some medications are applied, pharmacologic manipulations, and last resort is surgical. Nowadays they use some implant on the bladder wall. So bladder will send message to the brain by means of those implants that it's a time for him or her to evacuate the bladder. Implant. Like we do have pacemaker, external pacemaker. When my massive node is not doing their job, external pacemaker will kick in, my heart will go back to normal. If SA node is gone, external pacemaker is not working, didn't kick in, I'm on the ground. That external pacemaker. Similarly, we do have implants. They are now using technique, use implant on the bladder wall. Okay, so which of the following is not the cause of neurogenic? All other, we didn't mention about the Alzheimer's, so Alzheimer's is out. Alzheimer's disease is primarily a cognitive condition, not motor related. Forgetfulness. All these stress, incontinence, I take it back, all these incontinence are important. Now, we do have different forms of incontinence. Number one, we call it stress incontinence. Involuntary loss of urine during coughing, laughing, sneezing, or lifting weight. That's called stress incontinence. Increase because of that stress, because of the cough, or laugh, or sneeze, causes intra-abdominal pressure, and that causes leakage of urine, involuntary loss of urine. Or incontinence, involuntary loss of urine associated with strong desire to void. Urge incontinence. I need to go to that. Urge to, that's called urge incontinence. Overflow incontinence. Overflow incontinence, it is involuntary loss of urine that occurs when intravesicular pressure, the pressure within the urinary bladder, exceed the maximum urethral pressure because of bladder distension in absence of detrusor activity. And we do have mixed incontinence as the combination of stress incontinence and urge incontinence. So treatment option. Management depends on the type of incontinence, accompanying health problems, and person's age. Behavioral and pharmacological measures, exercise and strengthen the pelvic muscles, surgical corrections, known catheter, indwelling catheters, and self-catheterization. In elderly, they do have incontinence. Overall capacity of the bladder is reduced because of age. Now we do see over here, urethral closing pressure is reduced. As a result, every time there is some leakage of urine, patient is not aware, patient is fine, sir, but his clothes are getting wet. Detrusor muscle function declines with age. Advanced age, restricted mobility, increased medication, sometimes those sedative medication also causes comorbid illnesses, infections, and stool impaction, that is constipation. And also, please remember, we call we call overactive, make a note, we call overactive bladder syndrome. Overactive bladder syndrome. First, patient has uncontrollable desire to urinate. I can't control, I need to go to the bathroom. Frequency, people said, frequency of voiding, with or without incontinence, urgency. Sometimes these patients also get up at night. We call nocturia. Nocturia, Nocturia, nocturia. Patient will give the history that I'm getting up 2 or 3 times at night. But I don't have sound sleep. Patient become irritable in the morning. So that's overactive bladder syndrome. Overactive bladder syndrome. Now, this topic, it says bladder cancer now. Signs of bladder cancers. Patient will have a history of frequency, history of urgency, and patient will give history of dysuria, painful micturition. Dysuria is a painful micturition. An important one over here, above all, hematuria. That is a red flag. If the patient's urine is reddish, coffee color, reddish color, that means there is a red flag that something is wrong in the urine bladder. So whenever there is hematuria, patient with hematuria for a couple of weeks before he or she was fine, then the doctor should visualize the urethra and the urinary bladder. If during we call cystoscopy, when they see any lesion in the bladder wall, they need to take the tissue out, do the biopsy. If it is cancerous, remove it. Is it clear? Remove it. Not only sometimes, it depends. If it is superficial, you can take the part of the cancerous tissue. If it is already invaded, if already spread into the nearby tissue, then you need to get rid of the whole blood. That is called, anybody, what is that operation called? It's called, write it down, it's called cystectomy. Surgical removal of the urinary bladder, cancerous urinary bladder, is called cystectomy. Cystectomy, cystectomy. Because the report came that the patient has invasive bladder cancer. We can wait. So we need to talk to the patient that we need to remove your bladder because the cancer is already spread. Therefore, invasive. Cancer lesion is invasive type. Look at the PowerPoint. It's the invasive type. So only choice are left. I need to remove the urine bladder. Okay, now diagnostic measures, cytologic. Remember, we did this biopsy cytologic studies. It became cancerous. Excretory palography, cystoscopy, biopsy, ultrasonography, CT scan, MRIs. All these are the tools to confirm the diagnosis. Okay, treatment method depends on the cytologic grading of the tumor. That's why I said if it is local, if not, if it's superficial, we can get rid of the tissue instead of removing the whole blood. Number two, lesion degree of investment. If it's already invasive, is already invaded or invasive, surgery, total removal of the bladder. Method includes surgical removal of the tumor or the bladder, radiation therapy, chemotherapy. Oh, let's end. Oh. Okay. I think I discussed a lot of things out of the PowerPoint today. I don't know if you folks heard my story or not. All those stories are important. Maybe not in the PowerPoint, if you look at those stories as I mentioned during my discussion. Like UTI, urinary tract infection, is the importance. How the patient presents UTI. What are the risk factors for UTI? What are the causes of obstruction? If you look at the causes of urinary tract obstruction, maybe my enlarged prostate, maybe I have some tumor in the bladder, benign tumor or malignant tumor, doesn't matter, it still causes obstruction. Or I'm having a late-term pregnancy. Late-term pregnancy also causes urinary obstruction. Please remember, we discussed about the flaccid bladder. Bladder when become flaccid, when the bladder becomes spastic. We mentioned about, I said, please go over with all the incontinence. We discussed in the PowerPoint also, and all on page 1043. On page 1043, they discuss about urinary incontinence, like stress incontinence, urgent incontinence. On page 1037, they do have a topic we call physical examination of the urine. Physical examination of the urine, followed by laboratory and radiologic studies. Physical examination of the urine. And folks, also on page 1034, we do have the diagram for the sympathetic, parasympathetic, and somatic nervous system, which controls my bladder function. And also on page 1035, they discuss the mechanism of bladder emptying. Please go over and retain those, which we already discussed, but still it is very clear over here instead of the PowerPoint also. Okay, I think we are good. Yes. Folks, today he joined. Today, are you here? Okay. Stephen, are you here? Stephen, Hinting. Somebody with iPhone, I don't have the name of that person. And I mentioned earlier, if you join with iPhone, you don't have any ID. So please email me if you join with iPhone. I will mark you present. Okay, folks, we will wrap up over here. We're done for the week. Have a good weekend. Take care of the exam today. And also, everybody is doing good. Please follow the Pathophysiology guideline. Pathophysiology guideline. My sound level, my eyeball movement, watching on the screen, not looking here and there. Those are all those important for Pathophysiology. But otherwise, if I keep looking at here and there, Pathophysiology give me a sign that this student is doing something wrong. Suspicious. So please take care of it. I will see you folks next Friday.
Thank you, Professor.
Bye-bye. Folks, our Zoom will wrap up. I'll see you folks on Friday.
Hey, Professor, we're gonna meet on Friday, right? Next Friday? Professor, can you hear me? Professor? Hello? Professor, can you hear me? Hello? Professor? Can you hear me?
Okay.
Hello? Professor?
Professor, I think Tanya's trying to talk to you. Tanya.
Thank you.
Who?
Tanya.
Tanya?
Yes, I've been trying to call you. Yes.
Oh, Tanya, I emailed
Yes.
this morning.
No, I was saying that, say it again, Professor?
Okay, so sound is, can you?
What are you saying, Tanya?
I was trying to ask him, are we meeting next Friday?
Are we meeting next Friday?
Yeah, we are meeting.
We are.
We are.
Yes.
Next
Okay,
Friday,
all right.
last week.
Okay, thank you.
Thank you, Professor.
You got my email, Tanya.
I did. I got your email. Thank you.
Thank you.
Thank you, Professor. Thank you.
Missing next class in person because I do need to get my second dose of Moderna.
You are,
Miriam.
I think you emailed me.
Yeah, I didn't get a reply. I just wanted to make sure that you got the email.
So I need to reply you?
No, I just wanted to make sure you got it.
No, I got that one. I thought, yeah. You gave me the email. You are going for a second shot for next
Yes.
week or something like that.
Yes, so I just want to attend.
I got that one.
Okay, perfect. Thank you so much.
You're welcome. Bye-bye. Bye, guys, everybody.